Good afternoon, everyone. My name is Felicia Mburu, and I work with Validity Foundation. I'm based in Nairobi, Kenya, and I'd love to welcome all of you to our webinar today. Thank you so much for registering, and we hope that we will learn a lot today about the denial of essential services and how it links to torture and/or ill treatment. So, some quick opening remarks. This is the last webinar in a series of webinars around the, disability and various responses during a pandemic. The first webinar we started with was the situation of persons with disabilities in, we started with police violence and brutality against persons with disabilities during this pandemic. Then we followed with the second webinar on pursuing emergency deinstitutionalization through legal proceedings. We had a session discussing assessing the legality of restrictive measures implemented by states, and another on the situation of persons with disabilities in closed residential facilities. Our last session was on challenging discriminatory denial of emergency healthcare and triage policies. And therefore today we will be discussing the idea of essential services, the denial of essential services and how to achieve redress for victims of torture and/or ill treatment who are also persons with psychosocial and/or cognitive and/or mental disabilities. For that, we have 4 speakers who will guide us through this process. We have all of them distinguished in their fields and also persons who work in this field. So we have Ieva Leimane-Veldmeijere joining us from Zelda. We have Thandiwe Mkandawire joining us from Mehuka in Malawi. We have Lisbet Brizuela joining us from DRI, Mexico. And we have Chidi joining us from the University of Ottawa. Now, on to some quick remarks on why we decided to host this webinar today. Internationally, we've noticed that persons with psychosocial disabilities face stigma, isolation, and social exclusion on the basis of disability. This leads them to be exploited, experience a lot of violence and abuse, which remain common globally, not just in our countries that we live in. And when you look at what are the alternatives, there's generally no alternative except psychiatric facilities. And there are terrible practices such as tying, seclusion, and segregation within the communities in which they live in if they do not end up in closed settings. Now, in addition to the pre-existing mental health conditions, the pandemic has come to highlight the challenges that persons with psychosocial and cognitive disabilities face on a daily, but made worse through the pandemic. So they're already disappropriately affected in terms of service provision. There are very few healthcare facilities that provide for psychiatric care. There are few healthcare facilities, organizations, institutions that provide community-based services, which is what we're calling essential services. And even when a lot of countries started instituting lockdowns and social distancing measures, mental health services were not originally classified as essential services. So there was an impact out of that on persons with psychosocial disabilities. So this session will be exploring how the denial of these services has affected persons with psychosocial disabilities. What is the impact out of that? And how then can we seek redress for people who suffered acts of torture and/or ill treatment through that? With those few remarks, I would like to hand over to my co-moderator, Bruno, to just guide us through a few housekeeping rules, and then we will have each panelist start speaking after that.
Thank you so much, Felicia. Hi, everyone. Good morning, good afternoon, and good evening from all parts of the world. My name is Bruno. I work at Validity Foundation alongside Felicia. I'll also be co-moderating. Like Felicia said, I'm just going over some housekeeping rules for the webinar and just to help everyone to participate as much as possible in an accessible manner. First and foremost, I need to remind everyone that the webinar is being recorded. I hope everyone is comfortable with this. Also, whenever you're not speaking, please do keep yourselves muted. And whenever you'd like to speak, please use the raise hand option first on Zoom. If you're not familiar with that feature, I invite you to look at the bottom center of your Zoom screen, where you should see a button that says raise hand. When you press it, either me or Felicia will call out your name and allow you to speak. Especially since if you're a participant, we have to unmute you first to allow you to ask a question. Of course, participants in any case also have the option to use the chat box to ask questions, especially during the question and answer period of this webinar. When you do it, please send the question to everyone in the webinar so that everyone can see your question. So in any case, we want to make this webinar as accessible as possible and give everyone here the possibility to participate. If there's any concern or you need assistance of the organizers during this webinar, please contact either me, Bruno, or Zofia directly using the chat box, which should be open on the right hand. If you cannot see the chat box right now, perhaps you should just click on the chat button to be able to see it. Then finally, you will have noticed that this webinar has interpretation. If you just make sure that you're able to see the speakers and the interpretation at the same time, please use the gallery view mode on Zoom, which should be, if you notice on the top or top right, you should see an option saying view. And then if you select it, you should see the option saying gallery view. Just select it, and you should be able to see everyone that is speaking and interpretation. Finally, just to wrap up and allow our great panelists to speak, we would just really appreciate your patience if there are any technical difficulties. We will give you instructions to help overcome this if it happens. On that note, then I'll just give the floor again to my colleague, Felicia, who will introduce the panelists. Thank you so much.
Thank you so much, Bruno, and the rest of the team. Thank you for supporting us in the background. Now, at this juncture, I'd like to introduce our first speaker. This is Thandiwe Mkandawire. Thandiwe is the director of the Mental Health Users Network, which is based in Malawi. I always get it wrong. I'm not quite sure whether it's Lilongwe or Blantyre, but Thandiwe, maybe you could explain a little bit about that. And the question we have for you, kindly answer for us the question of what is an essential service for persons with psychosocial disabilities generally, and also in the context of this pandemic, what would you classify as an essential service?
Thank you for the introduction, Felicia. As mentioned, I'm Thandiwe Mkandawire. I work with Mental Health Users and Carers Association. It is based in Blantyre in Malawi. To answer your question, I think I'll start off with saying that although there's like widespread global recognition of the global and national economic loss, human rights violations, poor health outcomes, and premature deaths associated with mental health conditions, mental health remains under-prioritized and highly neglected area. Mental health is characterized by depression as one of the leading causes of disability, costing the global economy $1 trillion per year. People with mental health conditions often experience severe human rights violations that can amount to torture or cruel, inhuman, or degrading treatment or punishment. At its very worst, mental health conditions cause 800,000 deaths per year due to suicide, which is the leading cause of death amongst young people. However, treatment coverage is extremely low in low to middle income countries, and there's a lacking of sustained financing to scale up mental health services. Essential services means services that, if they're disrupted, would endanger the life, health, or personal safety of a whole population or part of it. So in describing essential services, Services that are safe, timely, equitable, and people-centered include availability of mental health specialists. So we're speaking of psychiatrists, psychiatric nurses, psychologists, clinical social workers, occupational social therapists. We're talking about institutionalized services, that is psychiatric facilities, mental health units in general hospitals for inpatient and outpatient care. We're talking about mental health care in primary health centers. This also includes community-based mental health care. So we're talking about mobile clinics, we're talking about outreach care for home-based support, day centers, peer support groups, and community mental health forums. In light of COVID-19 has had a very devastating impact on so many areas of people's lives. We're talking about loss of income, loss of family members, and the right to freedom. So we're talking about the measures, social distancing and isolation, so as to protect ourselves and others from infections. And this has had a devastating impact on mental health. And the impact of COVID-19 falls against the backdrop of many countries across the world only spending 2% of their national health budget on mental health. And as such, COVID-19 has had a devastating impact on mental health services. So we're talking about disruptions to services for vulnerable groups. So we're talking about children and adolescents. We're talking about women accessing prenatal and postnatal care. We're talking about disruptions to counseling and psychotherapy, disruptions to emergency interventions that include experiencing prolonged seizures, severe substance use, withdrawal symptoms, disruptions to access to medication, disruptions to school and workplace mental health services. In South Africa, for instance, 2.2 million people lost their jobs, and many more people experienced pay cuts. These disruptions to routine and economic activities has had a devastating impact on coping mechanisms and mental health. 56% of adults are experiencing higher levels of emotional and psychological stress to cope with the impact of the pandemic. Many people have resorted to unhealthy foods, alcohol, drugs, antidepressants, or anti-anxiety medications. In a study recently done in South Africa, it indicated that although the lockdown in South Africa resulted in 40 to 60% reduction in COVID-19 transmissions, however, one of the major findings was that although the participants did not link COVID-19 to their mental health, the study found a variety of stresses that caused deep worry, anxiety, and thinking too much in approximately 20% of the adults. This was driven by the inability to take care of themselves and their families, crippling financial concerns, personal vulnerability due to the illness, the invisible nature of the transmission of COVID-19 itself, and a lack of awareness of COVID-19. In Malawi, there's currently no existing qualitative and quantitative data on the impact of COVID-19 on mental health. However, in our work with peer support groups, our feedback is showing that there's disruption to mental health clinics. So this means that the clinics have been suspended indefinitely. Users can only access hospital facilities to collect their medication. So this means there's no counseling, there's no psychotherapy. There's shortages in drug supplies. Our borders have been closed, so that means there's delays in medication coming to the country. This means users of mental health services do not have access to drugs, or they're asked to switch to an available drug that's not compatible with them, or they're asked to access private pharmacies, which they cannot afford. So loss of businesses, loss of medication, and limited interaction with support systems has resulted to mental health conditions, people with mental health conditions experiencing increased mental health symptoms, relapses, and deaths. In Malawi, we have seen a 50% increase in suicide rates as compared to last year. Community mental health forums are reporting an increase in alcohol and substance use amongst young people. So how can we then link that to torture and or ill treatment? Looking at the first half of the definition of torture as described in Article 1 of the Convention Against Torture, the diversion of resources to COVID-19 response to the denial of mental health services during the pandemic has not been done to gain information or a confession or as a form of punishment or intimidation or coercion. Therefore, it will not classify as torture in that context. But if we start looking at it in terms of stigma and discrimination, personal prejudices and beliefs such as witchcraft, God's punishment, alluding to perceptions of moral failings for the person with a mental health condition, people in the citizens of the country or people in high public offices tend to have these stigma and discriminatory attitudes. We are all indoctrinated to accept certain ideas, beliefs, and attitudes. And indoctrination is linked to socialization. Socialization can either be viewed as bringing social order or social oppression. And for most people, socialization brings social order. Coupled with indoctrination, very few people, regardless of gender, race, economic status, will take a step back and critically analyze their ideas, beliefs, and attitudes, whether it be for race, gender, or mental health, therefore creating a slow environment for changing the mindsets of millions of people across the world. With indoctrination, socialization would create a world of privileges, no privilege, heteronormative privilege, white privilege, Christian privilege, and mental health privilege. Waking up every day not being burdened by feeling of fatigue, worthlessness, hopelessness, or suicidal ideation, burdened by depression, we assume a position of strength and superiority that our mental capacity has awarded us. Then we're having the ability to face life's challenges without succumbing to depressions. With indoctrination, socialization, and privilege comes stigma for persons with psychosocial disabilities. Stigma, a sign of disgrace and discredit, creates an experience of shame, blame, secrecy, isolation, and social exclusion and discrimination, which is one of the major reasons persons with psychosocial disabilities do not access mental health services. And mental health is also characterized by a lack of knowledge and awareness about mental health and mental health conditions. A lack of understanding can be classified as neglect. And it is, however, the neglect to not have mental health knowledge leads to the conscious decision to underfund the mental health field by high-level public officers and not prioritize mental health during the pandemic without considering the consequences. This has led to increased symptoms for existing mental health and neurological conditions, relapses, and deaths due to an increase in seizures or suicides during the pandemic. An increased presence of symptoms means increased experiences of delusions, hallucinations, uncontrollable highs and lows in mood and suicidal ideations, and increased frequency of seizures that occur across the day. It means being chained and locked up to be hidden from stigmatizing and discriminating eyes, or to protect you as a family member, or to protect you as family members attend to other family activities that provide economic stability. It means losing dignity and human rights. It means torture. Deciding whether denial of mental health essential services classifies as torture during the COVID-19 pandemic should not only be viewed based on the times we're living in, but to critically analyze the trajectory or the path of mental health before the pandemic and how the history of mental health across Africa and the world impacts the mental health decisions being made in the present. It is the decades of neglect, lack of understanding about mental health, stigma, and discrimination that has led to the current regression and the small strides mental health has made over the years. We have to acknowledge the pre-existing beliefs that the users of mental health services cannot be equal contributors to society, the belief that recovery is not possible, and as such, a waste of resources. It is the belief that users of mental health services cannot be awarded the same human rights as all members of society. When we acknowledge the indoctrination, socialization, privilege, stigma, and discrimination, we can then understand that it is an easy decision to deny mental health essential services that leads to pain and suffering, either physically or mentally, that it amounts to torture in reference to for any reason based on discrimination of any kind. Thank you, Felicia.
Thank you so much, Thandi. I know there will be a lot more to discuss after this, but thank you for setting the ground for us. Now, our next speaker is Ieva Leimane-Veldmeijere from, I'm going to say the name in English, then maybe Ieva, you can say it in Latvian, which is the Resource Center for Persons with Disabilities. And we will be covering the topic of around how then can we provide essential services, and especially in a pandemic. You'll be speaking based on your experience during this pandemic, providing essential services to persons with psychosocial disabilities. So Ieva, the floor is yours. Please proceed.
Hello, everybody. Yeah, as Felicia said, I'm representing NGO Zelda, which is based in Latvia. And we are actually right now one and the only one provider of supported decision-making service, which currently we provide to around 76 persons with psychosocial disability, and we also provide service to people with intellectual disability. Yeah, and I was asked to little bit to share our experiences and to elaborate about what is essential service in this pandemic situation. And the first what I would like to emphasize that there is no one right answer to the question, what is essential service? Because every person is different, and for every person, different services can be more or less essential. For instance, for somebody, it would be very important to continue regular visits to his or her mental health care specialist. For somebody else, would be very important to continue some started group activities like support groups or self-help groups. We also have a range of community-based residential services where people can live a supported life in the community, for instance, group homes or service apartments. I would say that pandemic right now has changed the perspective. We start to ask ourselves, what are the most important services, what cannot be replaced? In case of essential services right now, it's also it's important to understand which services should not be discontinued. And it's very important that people who receive certain relevant services, that they continue to receive them. And it's important to understand how we can organize these services differently. And as Felicia asked me, let me share experience of my organization in providing supported decision-making service during pandemic. As I said, this service, what we provide in main areas of life that can be various issues related to, for instance, to legal matters, including assistance in one's claiming human rights, finding place where to live, for instance, helping people to address some human rights violations and to seek redress. That can be also assistance in planning personal budget or helping to solve some issues with banks or creditors. And that can also be assistance in decision-making concerning simple daily issues, as well as assistance in access to healthcare or social care services, and also helping to communicate with medical professionals, which sometimes has been very useful for certain people we support. And the priority in our work is to facilitate the wishes, will, and preferences of each person we are supporting. And it's very important to say that we are not only providing support in making decisions, but we are also supporting people in implementing stage of their decisions, because we believe it's not ethical just to help somebody to make decision and then not to help to implement it. And what is important, our supporters never make decisions on behalf of the person. Their role is just to help person to understand the circumstances, the consequences of his or her actions in order to make his or her own decisions. And I think it's very clear in this current state where we are that it is very important that services that are provided, they are provided individually and they are tailored to the needs of each individual receiving the service. And one thing it's clear what we have seen, that it's very important to provide information to people we work with about what is happening, what are, for instance, rules people need to observe at current situation, how they can access assistance, how they can access, for instance, state-paid COVID-19 tests, how they can access healthcare specialists in case if ordinary previously known specialist suddenly is not available, and also various issues connected with daily life in some situations, especially if person needs to sit in self-isolation or quarantine. And in Latvia, since spring, and it's, I guess, similar to many other countries, since spring, we have seen the situation has been changing, and it can change from day to day. And for instance, in spring, we had 3 months long state of emergency. And at that time, we had relatively low level of COVID-19 cases. And right now, again, we have since 9th of November, a new state of emergency. Nobody knows how long it will take. The level of COVID cases are running high every day, and nobody knows where we will end up. So comparing spring and right now, it is much more depressing, much more difficult to cope with the situation. What does it mean in terms of providing our service? In spring, many service providers simply locked their doors. They were not available. For instance, day centers or municipal social services, where people would normally visit their social worker or apply for social benefits, they would close their doors. Also, various outpatient care services were not available. Only in case of emergency, people could call ambulance and hope to get some health care. And at that moment, we decided to continue to work. And during these 3 months, for several people, our service would be the only support service person would get. And we also were very flexible to provide it in ways like people would like to receive it. Somebody would like to receive it only through phone or video chat, but not everybody from supported people are familiar with internet or smartphones. Somebody would require some regular visits at home, and we still continue to do this. Some people would like to have regular walks outside, and some people just said, I am too worried and too scared. I just want to have some contact from time to time, but I don't want to be visited. So also we respected every person, how he or she want to maintain the contact. Now we are experiencing the second stage of emergency, as I said, from 9th of November, and now situation is very different. And now actually there's new rules from the government in place, and now we are allowed to provide service only if we want to meet face-to-face person. We are only allowed to provide service if this person have got negative COVID-19 test, and the test shouldn't be older than 48 hours. And yeah, we think it's not a very nice rule, because we believe it's people shouldn't be just pressed to make these tests, because first, it's not easy to get them without any symptoms. And second, we don't believe that people who live in a remote area, for instance, in some lonely, nearly in forest, for instance, why we should bring him to some COVID test just to have his face-to-face meeting with his supporter. There are different solutions to this. There are people who really just decide to have support through telephone or some video chat. There are, as I know, other service providers who just ignore the rules set by the government, yeah, we just have to see the way how to not to lose contact with people, and to still provide support they need to receive. Also, Felicia asked me to speak a bit about denial of these services, and where it can end up, and can it reach some level of torture or ill treatment. I think that we are facing right now totally new situation. Before COVID-19, it was more or less clear worldwide what are fundamental human rights and what rights cannot be denied. And in many countries, countries have constitutions, they have provisions where in certain situations it's said that human rights can be restricted. And actually, we are experiencing right now these situations where state decides to restrict certain human rights. Some countries might restrict certain rights more than necessary. And unfortunately, we have seen this happening also in our countries. And also what happens, what we have noticed, that certain service providers of social services have their own interpretation of laws and rules. We have seen that due to emergency state, people living in community-based group homes are basically locked up. They live behind locked doors and they are let out only together with staff for a short walk around the group home. We also have seen that correspondence with relatives and friends was restricted. In one group home, we find out that even after 3 months, when the state of emergency was cancelled, people were not informed about it, but still they were kept in ignorance that the situation has been changed. And they were not explained that they can freely move around in the community. In the same group home, we also find out that one resident, what we support, was threatened that if he will not follow the internal rules of group home, that he will be punished and locked up for 14 days in his room without possibility even to attend bathroom. He would get some portable toilet in his room. And my question would be, is it normal to restrict person living in community-based supported living setting to such an extent? And next question is how it differs from institution. In my mind, the only difference is the service, the title of service. And we all, I believe, have general understanding around the world that institutions for people with any sort of disability is not the place to live a meaningful life. And we all know that these places have many human rights violations. But I think it's also time for us to pay more serious attention about what's happening in these community-based residential settings. I think I see Felicia. Is it my 10 minutes over?
Yes, yes.
Okay, thanks.
Thank you. And there will be a chance we'll double back to you, Sach can give us a little bit more information. Now, to tie this all in together, I'd like to invite our third speaker, Lisbet, who works with the Disability Rights, DRI Mexico office. And specifically, we'll be answering the question on, first of all, what is the implication of denying or withdrawing these essential services? I know DRI recently launched a report about the impact of certain measures in institutional settings and how it's affected people, persons with disabilities. So just give us an overview of what's the implication of denial or withdrawal of these services and how it has either reached to the levels of torture and or ill treatment. Over to you, Lisbet.
Thank you so much, Felicia. First, I want to thank Validity for the invitation, and it's great to be here. I'll talk about the context in general terms in Mexico, the context in torture into the Mexican institutions, and the alternatives that we should implement in the country. First, I'm going to give some background of what's going on here. Well, Disability Rights International, it's an American organization with a regional office here in Mexico. And DRI has documented the situation of people with disabilities who are detained in congregated settings since 2000. Over the last 20 years, DRI has conducted an extensive documentation and brought international attentions to these abuse patterns by publishing 4 reports about Mexico. DRI has visited over 60 institutions in the country in different states, and DRI in each of the reports has detailed recommendations to the Mexican government for restructuring a service system in the country. However, the government of Mexico must be held internationally accountable. Almost certainly, no other country in the world has better informed about the implications of the laws and policies towards people with disabilities than Mexico. The Committee on the Rights of Persons with Disabilities and the Inter-American Commission on Human Rights have issued findings that support those of DRIs, putting Mexico on notice that its treatment of people with disabilities violate a broad range of fundamental rights under the CRPD and the American Convention. In October this year, DRI published the latest report, Crimes Against Humanity, Decades of Violence and Abuse in Mexican Institutions for Children and Adults with Disabilities. The report documents a grave and widespread human rights violation of children and adults with disabilities living in public and private institutions, including orphanages, psychiatric hospitals, group homes, and shelters throughout the country. According to DRI's findings, children and adults with disabilities are confined in institutions, segregated from society and exposed to these dangers because of the country has failed to create supports in the community that allow people to live their lives outside of the institutions. Mexico's law strips people with disabilities on the right to make decisions by their own, leaving them unable even to file complaints or demand accountability when they're abused. Sexual and reproductive rights of girls and women with disabilities are violated continuously. Sterilization and forced contraceptions are common practices in the Mexican institutions. And despite the forced sterilization of women with disabilities, it's banned by the Mexican Federal Criminal Code and criminal codes in 18 states. There's national standard regulations that for family planning services that establishes that mental retardation in women, it's an indicator for sterilization. To the absence of meaningful treatment, people with disabilities are often controlled through the use of physical or chemical restraints. DRI has observed, for example, children and adults held in cages and tied down to beds. There's a high mortality rates in residential institutions that have not been investigated. For example, there's a public facility and the authorities reported that there are at least in the 98 of approximately 300 people at the facility have died in the last 2 years to the misuse of psychotropic medications, which is a very high rate, but there are not investigations on what's going on here. The case of Mexico goes beyond the COVID-19 pandemic. Through the investigations, DRI has shown this pattern of systematic human rights violations against people with disability in institutions and has demonstrated the lack of action by the Mexican state to prevent abuses and change the model of institutionalization in the country. Mexican authorities do not even track the number of people placed within the system, and much less, they don't have any data or number of people infected or those who have died from COVID-19 in institutions. Over the years, DRI has provided a couple of recommendations for Mexico that can be used on this time of the pandemic. Some of the recommendations were published in the report in 2010, and those are: the right to community integration must be established under the Mexican law. The development of comprehensive plans that should be drawn up to integrate all people with disabilities in the community. New placement of children in institutions should be brought to the end. The importance to establish oversized mechanisms to protect children and adults' rights detained in institutions. For example, we haven't been able to visit institutions right now in Mexico because of the high rate of infections in the institutions. The authorities say they're doing things, but we don't have any way to look if they're doing it right or not. Their life treatment abuses and torture, including the abuse of restraints, must be brought to the immediate end. Access to justice must be ensured. Full participation of people with disabilities also must be ensured because they're not considered on this the effects, and throughout to the UN CRPD committee should include detailed information on children's and adults' human rights and adults detained in institutions. However, in order to change the situation that people face in the country and achieve redress for victims of torture, a higher degree of accountability is needed. The Mexican state is responsible for investing in institutions, prosecuting and punishing all violations should be done. Mexico also needs to change the culture of impunity. Mexico is one of the countries with the highest rates of impunity in the world. So in Mexico, the abusers are not held accountable, and the government's authorities fail to respond to know human rights violations in institutions. The knowledge of long-standing pattern and lack of institutional action to connect these tremendous abuses goes far beyond criminal neglect conduct. And the Mexican government also must create independent mechanisms for effective supervision and monitoring, especially during the pandemic. The lives of thousands of children and adults with disabilities depends on that. Thank you very much.
Thank you so much, Lisbet, and thank you for keeping it brief as well. But there's one other context that caught my attention when you were talking about institutions and institutions. Just a quick question for clarification. Are you talking about large-scale institutions or small group home type of settings?
In Mexico, there are all kinds of institutions. Like DRI has visited institutions with 500 people, or even been visiting institutions with 9 persons, for example. So all of them, you can find a range variety of torture and abuse. And people like tie down in small institutions or tie down in bigger institutions. So Mexico has no community services like other countries in Europe. Yeah. So the only alternative to people is institutions, and institutions are very abusive.
Okay, thank you so much for the clarification.
Thank you, Felicia.
Yeah. Now, at this point, I'd like to invite our fourth speaker, Professor Chidi. Please walk us through all of this that you had, because it sounds a bit unrealistic, like this does not actually happen in the real world, but we do know it's happening. We have the different examples of how denial of essential services is causing harm and human rights violations to persons with psychosocial disabilities. So take us to what is the standard of the law that we should be looking at here to hold persons accountable for these human rights violations, and at the same time also seek redress for these human rights violations.
Thank you very much. And thank you, Felicia and Validity, for the opportunity, and for my co-presenters for exciting me to be able to intervene at this point in time. Let us, for the brief moment we have, look at what is the purpose of human rights. Essentially, human rights is to enable every person, every human person, to realize their optimum potential, irrespective of whatever circumstances of their birth or categories of discrimination that they have to face in navigating the society. And it hasn't been very clear that pandemic is one of such situations, because this kind of experience happens maybe once in a generation, even though we are told that we should be expecting more. Actually, the starting point might well be the constitution of any democratic society. But beyond those, we know there are dictatorships that do not play by the rules. But the international human rights framework come in very, very handy. And one thing we should look at right now is some of the holes that will make it a little difficult for anybody to cash the promises of human rights. And my colleagues have made mention of the Convention on the Rights of Persons with Disability. And I want to draw attention to a few things. that convention has itemized 3 paradigmatic circumstances in which the state is required to intervene. One of them is armed conflict. Another is humanitarian emergencies. And the third one is natural disasters. Now, when you look at these 3, you recognize there is no mention of a pandemic. Well, you might argue that humanitarian emergencies or pandemic can trigger humanitarian emergencies. But given the experience we have had with COVID-19, it is now pertinent for us to begin to think about direct mention of pandemic as a trigger for state ability to protect its citizens whose human rights are being trampled upon. And this is very, very important. Now, when we look also at the Convention Against Torture, and it was mentioned a little earlier, probably by the first speaker, that convention is framed against the acts that occasion severe pain or suffering of physical or mental dimension or nature. Now, when you look at that and read it carefully, what you will find under Article 1 is that it was crafted in the context of extracting punishment or extracting information under a criminal setting. But that is not what we are dealing with in pandemic. So as lawyers or people who want to really hold the state accountable, we also don't want to dismiss this language easily. There are openings in that language that suggest that we might want to begin to hold the state accountable because there are alternatives we are given, and those have been highlighted in the previous presentations. There is no doubt that the way the states and non-state actors have treated people with psychosocial disability in a pandemic amount to inhuman, degrading treatment, not to even mention punishment. So the negligent acts of the state are very obvious in this context, whether in the global south or in the global north. We have seen people in confinement, either in seniors' homes or even in other contexts. For example, people are deprived of water such that the attendants don't want them to wet their diapers. They are not giving water to drink. So this is a very critical manifestation of where the state has failed. Then when you look at the tendencies in the global south, where we do not have institutional protection or institutional cover for treatment of persons with disability, there we have the agency of the community, the agency of the family, taking care of persons with disability in a pandemic situation. We should not make the mistake of focusing on institutions because the dynamics of the global south and the global north are different. Most of the statistics we are getting about the pandemic in the global north is talking about people in retirement homes, in concentration places where they are being taken care of. But in the global south, we do not, for the most part, send our aged parents in institutional homes. It is the agency of the community, the agency of the family, and a government will be failing in its human rights responsibilities if they do not find a way to exercise oversight in some of these communal settings. As much as these settings have a tendency to also provide for people that are suffering with psychosocial or mental or intellectual disability, in the pandemic more so, the government needs to exercise oversight to be able to understand and exercise some degree of superintendence as to how those people are treated. Now, let us also be clear. Human rights are not absolute, and we have said this over and over. But the pandemic creates emergency situations, and most governments have leveraged on this circumstance in order to claw back some human rights. And all the previous speakers have emphasized those already. Now, when states make decisions that do not mainstream human rights, for instance, most of the pandemic ordinances must have to be sensitive to the human rights of the most vulnerable persons. So these kind of interventions must be looked at must be looked upon from the point of view of their sensitivity to human rights. And this is the responsibility not only of lawyers, but for advocates to make sure they raise red flags when the states make interventions that are not sensitive to those whose human rights are suffering, particularly in a pandemic situation. So that will be walking a delicate balance, sorry. Now, the problem is less of restriction, but more of how these people are treated even under restriction. What happens in confinement, in incarceration, and in rehabilitation homes? Those are really very important. Not that there would not be restrictions. We have recognized that the pandemic raised significant context for restrictions, but you can restrict and exercise that very leverage in law with human rights sensitivity. So those public interventions have to make sure that they mainstream the requirements of human rights. Now, when you look at how we have treated people with psychosocial or mental or intellectual disability in a pandemic, what you will need to pay attention to is that we have an opportunity to tap into what has been developed internationally. Now, if you look at the Convention Against Torture and the Convention for the Rights of Persons with Disability, they have optional protocols. Unfortunately, governments, mostly of developing countries, have yet to even begin to sign onto the optional protocol, particularly on the Convention Against Torture. This is one other instrument that needs to be revived at a time like this so that people will be able to hold governments that are accountable at international level. So part of the advocacy required is to begin to hold governments, to put them under pressure, to sign on to these optional protocols so that we will be able to hold them accountable at the United Nations. So to summarize, there are so many avenues, constitutional, there is also the international human rights framework that will enable us begin to hold governments accountable. There will be restrictions, but what happens in restrictive spaces? Governments have been abdicating their responsibilities. So we have to begin to use the whole idea of acts of omissions of government, because most of the acts are acts of omission as opposed to deliberate acts of punishment. So the negative and positive human rights obligation have to be completely harvested in order to hold states accountable. We have to have oversights, human rights oversights, to extend to informal spaces, to family, to community, and more importantly, particularly in the developing world, government has to have what we call a viable or functional data in order to identify who is a disabled person, who is suffering more than others under the pandemic, who is likely to fall under the crack. So these information are necessary even to support non-governmental organizations who work in this space. And when government derelicts or fails to exercise some of these responsibilities, then they have given rise to a situation that leads to torture. If not torture technically, one that creates an opportunity for inhuman, degrading treatment coming close to punishment or torture. Those are really flexible frameworks. And the conventions has also allowed the states to create their own laws that will have a more liberal approach to what constitutes torture. So there is an opportunity not to even be limited to the confines that the conventions have provided for. And so I know there'll be a lot of robust moments for interaction. So I'll be able to stop it at this point and see what happens next. Thank you very much.
Thanks so much, Chidi. It was great to hear your legal perspective regarding the topic of this webinar and about the concept of torture and ill treatment and how it applies in this context. Um, so now that we had our four speakers making their presentation, we would like to open the floor for questions from attendees. As explained earlier at the beginning of the webinar, please use the feature raise hand option to signal to us that you like to ask a question. And then we'll unmute you. Any questions that you'd like to ask the speakers? Masha, please go ahead.
Hi, I just wanted to ask for countries who have not already taken actions to uphold the UN protocols, the optional, especially the optional ones. What would you recommend as strategies for disability advocacy groups for recommending the coverage of essential services for people with disabilities, particularly?
Good question. Thank you, Masha. Who would you like to take it among the panelists? Chidi, perhaps?
Okay. Thank you. I hope I understand the question properly. What I have found is that the optional protocol, particularly with regards to torture, as in comparison to the one with regard to disabilities, governments are shying away from signing on to this protocol. And for obvious reason, because we recognize that the definition of torture, most police establishments, particularly in the global south, they do torture. And like, as I said, the pandemic has never been an issue that has been captured in strategic human rights instruments. And so there is need to put some pressure. I have always said that in a situation such as the pandemic, we are not likely to make significant progress unless we mount significant public awareness campaign. And there are no better partners to do that than most non-governmental organizations, particularly Validity. This awareness campaign is what calls out governments. For instance, most people do not even know in their areas of jurisdiction whether their government have signed on to this optional protocol. And they meet daily with ministers in charge. They want to ask questions. When a new country has signed a protocol, you might say, hey, Malawi just signed this protocol. What is happening in Zambia? What is happening in Namibia? It is so important that we continue to put pressure on these governments, because governments will not willingly sign this protocol because it opens them up to accountability. It opens them up to litigation, as you have seen the success that has been made by the Inter-American Human Rights Covenant. So many states should be so sensitive as to what they have been signed up to. So, but the pandemic creates a new opportunity. And let me say this, apart from the optional protocol, the two major human rights instruments, they have dedicated rapporteurs on torture, on rights of people with disability. For people litigating in this area, those people or those rapporteurs have developed what I consider to be significant space for interpreting all of the provisions, even at national constitutional level. So there is really a strategic need for us to begin to put pressure on states and to begin to leverage the jurisprudence that are being developed across the works of the special rapporteurs and how they have begun to really interpret what it means to torture and in different contexts. So the whole idea of it has to be deliberate action by the state, no. The relictions by the state, acts of omissions by the state are now tantamount to torture, particularly in a pandemic. So this idea of even professional groups, let's be very clear, non-state actors can be held accountable. So some of the medical establishments, paramedical establishments, particularly now that we have to deal with vaccines, if you are trying to bring about an ethical protocol to determine who gets what first and at what circumstance, you are required to be sensitive to human rights obligations and not take decisions, whether by omission, that will occasion abuse of human rights for the most vulnerable. I hope I was able to answer this question. Thank you.
Thank you so much, Chidi. Don't know if there's other attendees that have other questions or even panelists, other panelists would like to add anything else. Just a reminder, attendees have the raise hand option on the bottom of the screen, so you can use it to indicate you'd like to ask a question. All right, if we don't have any takers, then I have additional questions that I would like to ask attendees and speakers. Whenever possible, it would be great to have a discussion about this. So, especially in previous webinars, and also it came up in this discussion, a lot of the focus on the and discussion during the pandemic is about it's focused more on institutions than in community settings. So my first question is, and this is directing to the panelists, and of course attendees can also share their thoughts. In your view, should denial or stopping provision of personal assistance to persons with disabilities that need them in the community should be considered ill treatment? What do you think? Any takers? There's no volunteers. I was wondering if Ieva, could you, what do you think of the question that I asked?
I think it's always very difficult to say at which moment we can call it ill treatment or not. But as we have seen, sometimes people what we support, in case if he lose, for instance, his supporter, person might not access at that moment some certain I would say services what he needs and what he cannot access without this personal assistance what we are providing. That can be, for instance, some doctor's appointment what person is not able to reach by him or herself. We had first, for instance, person with breast cancer in spring, and it was very crucial that our supporter was continuing to work even in conditions when all the healthcare services were not available, but these very relevant and essential healthcare services were made available. So it was very important for this person to receive the relevant treatment on time. And I would say this can be very even life-threatening for some person if he not receive needed assistance at that moment. Yeah, that would be my answer. But it's really that's why I always say that each situation is very individual, and all the supports needs to be very flexible and tailored to these individual needs. So yeah.
Thanks so much, Ieva.
Can I weigh in there?
Yes, please, Chidi.
And I was so happy you asked Ieva that question, because what happens in a specific case is different from another.
Chidi, sorry, can you turn on your camera?
So what happens in a specific case is different from another. I have tried to raise the issue of what we call intersectionality. So a specific case, if somebody is being deprived of their personal assistant, you have to look at that. What is the purpose of that assistance? If it is not provided, what is the consequence? And then you look at the individual. Is he somebody that is physically immobilized? Is he a mother that has 2 kids in school? Is he a widow? What is this? What are the overarching context or interactions? What are the barriers even beyond that personal assistance that is being deprived? So all of this will come together to enable us make a judgment call, whether the circumstance that has been created gives rise to degrading and inhuman treatment. I have always been careful that we do not treat individuals in isolation of multiplicity of barriers they have to negotiate. Some of them are gender, some of them are race, some of them are, in fact, on the basis of social orientation, and they are requiring assistance for X. And so when all of these come together, you should be able to catalog the kind of barriers or discriminations that have come together in one specific case. And then you should be able to make the judgment call whether this has given rise to inhuman, degrading treatment or not. So I think she was right in her presentation when she said it's a case-by-case kind of situation because no two cases are specifically the same.
Thank you so much, Chidi, for your insights. I noticed that Masha might have additional questions. Please go ahead.
Yes, I have another related question. For a lot of institutions that have community-based human rights oversight, due to COVID, the campuses are oftentimes closed and the monitors are not available to, there's an inaccessibility for advocates to be physically present in institutions as well as a lack of community access. And so what would be some strategies to try to get like documentation or to try to maintain and monitor oversight of the institutions during the pandemic?
Thank you so much, Masha. Lisbeth, I think this question is actually perfect for you. What do you think?
Yes. I can't turn my video on, but for us, it's been very difficult to monitor institutions in the country. What we've been doing, for example, is to work with the local human rights commissions. Mexico has 32 states, and we have a very good relationship with a couple of the commissions. So what we're doing is to work with them in order to learn more about the situation of people living in institutions. But it's also hard for them. They don't have too much experience documenting or the situation in institutions. So, or they consider what the states are doing is fine. So part of our work also, it's kind of training these commissions, these human rights commissions, in order to get the information. In the case of Guatemala, that we also work there, what we're doing is we have contact with the staff there inside. So the staff is telling us all what's going on in one of the institutions in Guatemala. So they're our source of information, but I think it's also important to implement other measures using technology in order to monitor the institutions. For example, in the case of Guatemala, one thought, one idea that we've been thinking about is to use video. The ombudsman there and the staff can go to the hospital and use the camera and record everything what's going on, and then they can share with us the information. But this is something that we're just beginning to see how it works, or how can we make it possible. But I think it's important to implement other mechanisms, and our communication through the staff, it's through WhatsApp, and they're trying to get us more information, and that's the way we're documenting now.
Thank you so much, Lisbet. Do you notice from the chat box when another attendee has a question? But before moving on to that particular question, I would like Thandiwe to weigh in on the previous question that I asked about whether denial or provision of personal assistance should be considered ill treatment. And also have a follow-up to that. Do you think actually provisional of the personal assistance should be considered redress? What do you think?
Okay. Okay. Just to add on, I think to what Chidi said, it should be considered as a case-to-case in terms of personal assistance. Because now if you come to Malawi, there are no policies for personal assistance. So it should also be taken into context of country to country. What are the policies in that country? What are applied to persons with psychosocial disabilities, but to all persons with disabilities when they do not have access to personal assistance? So if there's that kind of neglect coming from high public offices, that then trickles down to different public offices. And then you're having persons with psychosocial disabilities not being able to have a person who can advocate for them, possibly have an ombudsman advocate for them when they're going to different facilities to access essential services, it be institutionalized or community-based. So if they cannot have that, then that can amount to ill treatment or torture, because then they're limited in the services that they can access.
Thank you so much, Thandiwe. Now, just going to read the question out loud from our attendee, Benan Cavalli, saying human rights can be limited due to public interest. What actions can be taken for persons with mental disabilities who face the arrest and brutality for violation of COVID-19 SOPs? Imagine is COVID-19 related measures. Who would like to take this question?
Okay, let me start first.
Sure, go ahead.
So the question has two angles to it: arrest and brutality. And so let's talk about arrest first. It goes to what I said earlier, that when states make laws or ad hoc laws or emergency laws as a result of the pandemic, they have a responsibility to make that law to be sensitive to the human rights test for everybody, including those with disability, including in a situation of pandemic. So one of the loopholes, at least in the international framework, is that pandemic has not been cited as one of those things that the states should be careful and mindful of when they are making laws relating to human rights. And I'm saying it is about time, because we have been told that scientists are telling us that this may not be the last pandemic in our generation. And so COVID-19 has opened our eyes to that reality. So if a state fails to make its emergency ordinance human rights sensitive, so if they go about arresting people that they are supposed to be protecting, it is not anything radically different from what we demand of them when people go for public demonstration as expression of their rights. Now, what about brutality? Under no circumstance, when you arrest, fundamental human rights tells you you cannot detain people you have arrested for more than 24 hours in many constitutions. And then when you arrest, you are supposed to apply that principle. And then when you recognize that the person you arrested is a vulnerable member of the society, there is no reason for brutalization. And therefore, that person is entitled to seek redress, because we expect that the law under which they were arrested must have been sensitive to a circumstance like this. And if they did not capture that circumstance, that is to say that this individual needs help, not arrest, not brutalization, then there is a basis to seek redress in a very significant way, because the essence of human right is to preserve the dignity of the human person. But if somebody who, by reason of their mental state, are already in dignity deficit, the state has a responsibility to protect them, not to arrest or to brutalize. And even when they arrest, because somebody may be wandering because of mental disorientation, if you put them into custody, you will seek help for them appropriately, whether in a rehabilitation home or make the call to social welfare, or depending on what is operating. But what baffles me is that the police in most developing countries have no idea whatsoever that their responsibility is to protect the citizen and not to brutalize them.
Thank you so much, Chidi, for your insightful intervention. So we're 15 minutes, well, about 15 minutes before we finish, probably a bit later. So thank you. So I would like to thank all attendees for your questions and the answers from your panelists. It was really great to hear from you. At this point, I'm going to pass over to my colleague Felicia, who will wrap up this webinar. Thank you so much.
Thank you so much, Bruno, for moderating that session. And thank you for the questions that came through. So I'm just going to do a quick summary of what we have learned today, and then we'll end the webinar. So one of the things we've learned is that essential service is, it's not a blanket application. It has to be individualized to the person, but at the same time, it still has to be provided, even in situations of pandemic or risk or things like that, because the outcome is, if you do not provide the service, it will lead to levels of ill treatment for persons with psychosocial disabilities. We have also learned that there are standards set. Even if the contexts are different, the standards still remain the same, in that we have to uphold the dignity and the rights of persons with psychosocial disabilities, whether it's in institutional settings, as we are seeing in the North, or it's in the family community settings, as we are seeing in the South part of the globe. We have also learned that redress is important. We cannot underestimate the issue of accountability for governments and also non-state actors, because the UN Convention Against Torture does put in these obligations on state actors and also to some extent non-state actors. And finally, the one thing we have learned is we need to look at torture and or ill treatment from a different context, because the pandemic is changing the conversation. We had the traditional acts of torture, which everyone would think about, but pandemic has shown us that torture can also be found in other contexts, especially in the health rights field and in the disability field, but we need to put our mind to it. So with that, I thank all of you for attending. I thank all our panelists so much for your presentations. A lot of eye-opening information, a lot of stuff that we need to digest slowly. And if there are any further questions, feel free to send them to Validity. We will communicate, Validity's email, and we will answer them offline as fast and as soon as possible. I thank my boss and my colleagues for helping me, my supervisor, especially. I've seen you here. Thank you so much for giving us this opportunity to talk about the work we do and how to achieve redress for victims of torture who are also persons with psychosocial disabilities. In the chat box, my colleague Sophie has posted the link where you can find more information on our website and our social media pages. And This being the last webinar of this series, I'm obligated to inform you that we will be releasing an anthology of papers based on all the webinars we've had in this series, and we'll publish them at a later date, which we will also keep following our website for further information. Thank you all, and have a lovely day, evening, or night, depending on which part of the globe you are at.